Welcome to this video. In this video, we're going to discuss dysentery. So I'm going to help you understand dysentery, know the causes, the types of dysentery, and also the management. Let's get started. Dysentery is defined as an intestinal disorder which is characterized by inflammation, abdominal pains, and painful straining to empty the bowels, with diarrhea often containing blood and mucus. The main causative organisms of dysentery are the Shigella species, the internal invasive Escherichia coli. We also have the external hemorrhagic Escherichia coli. Apart from that, we also have the Yersinia enterocolitica. We also have the Salmonella species. We have the Entamoeba, histolytica as well. So these are the main causative organisms of dysentery. So there are two main types of dysentery. We have the bacillary dysentery, also known as the shigellosis. We also have the amoebic dysentery, also referred to as amebiasis. So let's discuss each type of dysentery. So we're going to start by discussing the bacillary dysentery first. So bacillary dysentery is an acute inflammation and ulceration of large intestines, characterized by small frequent bowel movements consisting of blood and mucus in stool. Bacillary dysentery is caused by non-mortal gram-negative bacteria of the genus Shigella. This Shigella has 4 strains. There is the Shigella flexneri, there is the Shigella boydii, there is the Shigella dysenteriae, there is also the Shigella sonii. So those are the 4 strains of the Shigella. The predisposing factors are best summarized by the 6 F's, which are the vomits, food, feces, fingers, fluids, and flies. If these are well taken care of, then the problem is solved. The predisposing factors include poor feeding methods such as use of dead feeding bottles for infants, eating and boiled and improperly prepared foods, poor personal hygiene, especially hand hygiene, poor sources, treatment and storage for water to drink, as well as poor sanitation such as lack of rubbish pits or dumping sites, broken sewerage lines, as well as overcrowding. So these are some of the predisposing factors. Let's look at the epidemiology and transmission of dysentery. So dysentery is most prevalent in unhygienic areas of the tropics. But because it is easily spread, sporadic outbreaks are common in all parts of the world. Bacillary dysentery occurs among confined populations, such as those in nursing homes, large institutions subject to overcrowding. The route of transmission of Shigella is fecal-oral route. The bacilli is excreted in feces and then spread to humans through poor sanitation, bad hygiene, and contaminated food and water. Flies also frequently cause contamination of food and are prevalent mode of spread of dysentery. So the incubation period of the Shigella is 1 to 7 days. When the bacillus enters the gastrointestinal tract, which is the GIT, it invades the large intestines, causing inflammation of the mucosa, which eventually leads to ulcerations and bleeding of the mucosa. The bleeding causes the stool to be blood-stained and mucoid. In the later stage, pus forms due to infection. Adjacent lymph nodes may be affected, resulting into fever. So now, when it comes to the signs and symptoms of bacillary dysentery, you find that there's going to be certain onsets of signs and symptoms. Then fever is going to be present, which is caused by the infection and inflammatory reaction. There's also going to be dehydration, which manifests as loss of skin turgor as a result of diarrhea. It is important to note that in some cases, diarrhea may or may not be present because the patient passes small amount of stool, but it's the frequency which is increased. There's also abdominal discomfort. Abdominal discomfort is due to irritation of the mucosal lining of the GIT by the bacteria. Usually, this is an early symptom of dysentery. There's also nausea and vomiting, which is as a result of irritation of the mucosal lining of the GIT, specifically the stomach. Apart from nausea and vomiting, we also have colic abdominal pains, which is due to inflammatory reactions in the mucosal lining of the intestine. And the last one is bloody diarrhea, which is due to damage of the mucosal lining of the large intestines during inflammation. Damage to the mucosal lining may also cause damage to the capillaries. The passage of blood diarrhea is usually accompanied by urgency and tenesmus. Urgency is the urge to open bowels at very frequent intervals, even if small amounts of stool are passed. And tenesmus is a painful, ineffective straining to empty the bowels. The aims of management are to correct electrolyte and fluid imbalance, eliminate the causative organism, and to prevent as well as manage the complications. The investigations that are done includes microscopic examination of a fresh stool specimen and a rectal swab for culture and sensitivity. Stool should be cultured within a few hours of collection. Once an organism is detected in the stool, that confirms the diagnosis. Immunofluorescent techniques are used to detect organism in stool. Sigmoidoscopy is also done to review a red bleeding mucosa with patches of necrotic membrane which may separate to leave ulcerated areas. The therapy that can be given to this patient includes fluid and electrolyte replacement. Under fluid and electrolyte replacement, you are given oral rehydration. Okay, so you're doing this to restore fluid and electrolyte imbalances. However, each patient should be assessed for the degree of dehydration so that you can give the appropriate fluid replacement therapy. There are also drugs that are given apart from the fluid. Drugs are given as you're waiting for the results of culture and sensitivity. You can give antibiotics. These antibiotics that are given, the reason they are given is to shorten the duration of illness and prevent relapse. So you can give any of the following antibiotics. You can give nalidixic acid 1 gram 4 times daily for 7 to 14 days. You can also give ciprofloxacin 500 milligrams twice daily for 5 days. You can also give trimethoprim, sulfamethoxazole, which is also known as cotrimoxazole or Septrin, 960 milligrams twice daily for 5 days. You can also give chloramphenicol 50 to 100 milligrams per kg body weight 4 times daily for 5 days. And the last drug that you can give is ampicillin 500 milligrams 4 times daily for 5 days. So that is all I can tell you about bacillary dysentery. Now let's discuss amoebic dysentery. Amoebic dysentery or amebiasis is an infection of the large intestines caused by a single-celled parasite or protozoa known as Entamoeba histolytica. The predisposing factors are the same as those of bacillary dysentery. when it comes to the epidemiology of amoebic dysentery, Entamoeba histolytica has a worldwide distribution and is endemic in most countries with poor sanitation and low socioeconomic conditions. Use of human excreta for agricultural purposes favors the spread of the disease. The organism is acquired when cysts are ingested. So, Entamoeba histolytica is transmitted through the fecal-oral route by vectors such as flies, cockroaches, and rodents, which are capable of carrying cysts and contaminating food and drink. The incubation period may take 2 weeks or years. Human beings are the principal carriers or reservoirs. So when it comes to the pathophysiology, ingested cysts enter the GIT through the mouth to the stomach, where they encyst during digestion. Motile trophozoites are released, which multiply. Then they invade and ulcerate the intestinal mucosa of the large bowels. The ulcers they form are flask-like. Some of the amoeba go through the mesenteric artery and reach the liver, causing total destruction of the liver and resulting in amoebic hepatocellular necrosis followed by liver abscess. The signs and symptoms of amoebic dysentery includes gradual onset associated with abdominal discomfort, mildly loose stools or flank diarrhea with or without blood and mucus. So diarrhea may alternate with constipation. Tenderness may develop over the cecum, transverse colon, or sigmoid. Fever may be present. Abdominal pains may be on and off. If there is hepatic amebiasis, there would be body malaise, swinging temperature, sweating, and enlarged tender liver. There is also foul smelly stool. There is also weight loss, especially in chronic cases. Let's look at the management of amoebic dysentery. So we're going to do some investigations. So we're going to take stool for microscopy, culture and sensitivity. We're going to check if there is any history of blood-stained stool. We're going to do physical inspection, which will review dehydration. We're going to do rectal swab culture. We're going to take blood for HB. We're going to do sigmoidoscopy, which is going to review ulcers. We're going to do a liver scan, which is going to review liver abscess. After the investigations, then we're going to look at the treatment, where we're going to give metronidazole or Fladil, 200 to 400 milligrams 3 times daily for 5 days. You can also give Septrin, 960 milligrams twice daily for 5 to 7 days. You can also give Faramide, 500 milligrams 3 times daily for 10 days. So for hepatic amebiasis, you need to give Flagyl or metronidazole and chloroquine, 600 milligrams once daily for 2 days, and then 300 milligrams once daily for 21 days. You can also give paracetamol or Panadol, 500 milligrams or 1 gram 3 times daily for 3 days. Then for the fluids, you can give Ringer's lactate. Okay, so it will also depend on the degree of the dehydration. So it depends with the patient. So the nursing care of dysentery. The aims of nursing care is to prevent further spread of infection, to replace lost fluids and electrolytes, to prevent complications such as shock, to identify any contacts. Okay, So specifically, the nursing care of patients with amoebic dysentery, first thing that we're going to do is to look at the environment. So we're going to admit the patient in an isolation room away from other patients to prevent the spread of infection to other people. The room should be well lit for easy observation and well ventilated to promote air circulation. The patient should be nursed near the toilet for convenience. Equipment such as drip stands, intravenous sets, and observations tray should be within the patient's environment. After the environment, then we are going to do observations. So we are going to observe the general condition of the patient, monitor the vital signs such as temperature, pulse, respirations, and blood pressure frequently. So the frequency of vital sign observation depends on the patient's condition. So observe the quality and amount of stool passed by the patient. Monitor the intake and output and record on the fluid balance charts. Monitor stool for amount, consistency, and color and report. Observe for any signs of dehydration such as loss of skin, elasticity, sunken eyes, and thirsty and dry mucous membranes of the mouth. After you are done with the observation, then you need to look at infection prevention. So isolate the patient away from other patients to prevent the spread of the infection. People who come in contact with this patient should observe isolation techniques such as putting on gowns and masks whenever they enter the room, washing hands before and after attending to the patient. Restrict visitors because they can also get the infection. The linen which is used by the patient should be disinfected with jig 1 to 6 and should be labeled infectious before sending it to the laundry. So it should not be mixed with other linen from the wards. Administer also prescribed medication to prevent the causative organism. All utensils used by the patient should be disinfected. When you are done with the infection prevention, then you need to look at the nutrition. So give some copious drinks and a light diet free from irritants. If the patient is unable to take food and fluids orally, commence him or her on intravenous fluids. Maintain strict intake and output. Record the intake and output. Okay. The time of the intravenous fluid was commenced, the type of fluid, and the date started. You also need to look at the hygiene part. So give the patient assisted bed bath, depending on their condition, to promote comfort, self-esteem, and to remove dirt. Assist the patient with oral care to prevent complications of a dirty mouth such as mouth infections, and also promote salivation as the patient's mouth can be dry due to excessive loss of fluids. Change the linen whenever soiled and disinfect the linen with jig 1 to 6 before sending to the laundry. Ensure perineal area is cleaned. You can also look at the psychological care. So patients with dysentery may feel as if they have been neglected. The nurse needs to give proper psychological care to allay anxiety. Educate the patient about the disease process, which should include the cause, the mode of transmission, signs and symptoms, treatment, and complications. Explain to the patient the reason for isolation, which is to prevent the spread of infection. Explain also to the significant others why they are not allowed to visit the patient. Any procedure which is done to the patient should be explained to gain their cooperation. Allow the patient to ask questions and answer them truthfully. When you're done with the psychological care, you can also look at the medications. So administer the prescribed drugs. Okay? Once you administer those prescribed drugs, observe for side effects. Administer the fluids according to the patient's condition as well. When you're done with the medication part, then you can also look at the elimination. Observe the intake and output and record them. Observe the stool for amount, contents, and odor. Provide a bedpan in the initial stage, but as the patient's condition improves, encourage the patient to go to the toilet. Now, let's look at the prevention and control of dysentery. Dysentery can be prevented by applying the following measures. Improved environmental sanitation. So this includes the provision of safe and adequate water supply, safe and adequate disposal of human excreta through use of pit latrines or toilets, food safety against fecal contamination, provision of information, education, and communication about dysentery, discouraging the use of untreated human excreta for manure. Another measure is early diagnosis and treatment of cases and carriers. So prompt detection and appropriate and adequate treatment of both cases and carriers. Then regular screening of food handlers. Another measure is improved personal and communal hygiene. Adequate and washing with soap under running water after using toilet and before handling and eating food. Use of pit latrines or toilets for defecation. Children should not be allowed to defecate on the ground. Toilet training pots should be used and disinfected after use. Children's stools should be disposed of in the toilet or pit latrines. Boil water for drinking and for washing vegetables and fruits. Avoid eating uncooked vegetables and fruits salads. So these are the measures put across to prevent dysentery. Complications include perforation of the colon, peritonitis, rectal prolapse, hematogenous dissemination of the shigellas, which is rare, causing abscess and meningitis, acute non-suppurative arthritis involving large weight-bearing joints, which may occur during convalescence, then conjunctivitis, iritis, and peripheral neuropathy. So peripheral neuropathy is rare as well. Hemolytic uremic syndrome, which usually occurs 7 to 10 days after the onset of the disease. There is also toxic megacolon, hemiplasia, encephalopathy, septicemia, Reiter's syndrome, hyponatremia, as well as liver abscess. I hope you now understand the definition of dysentery, the types of dysentery, the signs and symptoms of dysentery, the diagnosis, as well as the management of dysentery. So this is all I had for you. See you in the next video session.